Hi, welcome to a review of the ICD-10, excuse me, ICD-10 Coding Manual, chapters 4 through 17. This review will be over chapter 17, Congenital Malformations, Deformities, Chromosomal Abnormalities, chapter 18, Symptoms, Signs, Abnormal Clinical and Laboratory Findings, chapter 19, Injury, Poisoning, and Certain Other Consequences of External Causes, chapter 20, External Causes of Morbidity. Thank you for joining me today. My name is Professor Schleicher, and I will be doing a review of the chapters with the official coding guidelines by PowerPoint, and you can follow along in your coding manual. Also, if you're using any type of a textbook, these will also match what is in your textbook, so go by just the title. So let's get started. So open up your coding manual to the following chapters, and we're going to start with chapter 17, and that reviews congenital malformations, deformities, and chromosomal abnormalities. And you'll notice that the codes are Q00 to Q99. So as you take a review of chapter 17, I always tell my students that you should take the big picture. Take a look at the big picture of what you're going to be coding out of these chapters. You've moved fairly almost through the coding manual, and so you are getting very familiar with the coding process. You should know how to use the index to the tabular, and as I talk about it, I backtrack through. After I find my code, I go to my subclassification, my classification, my category, my section, my chapter, and then we go back into the official coding guidelines that begin at the beginning of the chapter. And there are several exercises and examples of questions and diagnosis that you can code out. So, excuse me. You'll start with the congenital malformations, nervous system, eye, ear, face, neck, circulatory, respiratory, left palate, and digestive system will be included in these chapters. We move into genital organs, urinary system, musculoskeletal, and other congenital malformations, and then chromosomal abnormalities. So you can see it covers quite a fair range of these anomalies. Again, a congenital anomaly, malformation, or deformation is an irregularity, abnormality, or a combination of abnormalities that are present at and existing from the time of birth. So a chromosomal abnormality is an irregularity in the number or structure of chromosomes that may alter the course of the development of the embryo. And I'm going to move over here just a little bit since we kind of know what we're reviewing. So those congenital conditions are grouped into subcategories, and you've heard me talk quite a bit about the subcategories in past lectures. They identify the type of condition present. So for example, if you see the category Q61, and open up your coding manual, go to the code Q61, it tells you it's a cystic kidney disease and the specific form of it that exists. So as you make your way down under that category, you'll see excludes one note, and then that we need a fifth digit by the little red box, and it will give you the congenital abnormalities that are under a cystic kidney disease then. So you'll see congenital, polycystic fall underneath that. Other categories will provide specificity according to the anatomic site and combination of those congenital conditions also. Codes are not to be used on the maternal record, okay? Codes are only to be used on the infant or the patient's record who has that condition, so keep that in mind. A lot of times when we are coding, we have the mom's chart up and maybe the babe's chart because we go back and forth between the two. So make sure that you are only putting these congenital anomalies on an infant, okay, or patient's record who has the condition. So maybe you are seeing a new patient or a new baby, a new person, and you can go back and to these conditions then. So when an infant is born with a congenital anomaly during this encounter, the first code is from category C38 for newborn status, and an additional code is used for congenital condition present at birth, which you learned that in a previous chapter when we went over to the babies, coding out the babies charts. Always have that Z38 code. So, some instructional notes for Chapter 17. If an infant is transferred to a second hospital for care of a congenital condition, the principal diagnosis at the hospital would be the congenital anomaly. So your first hospital is coding out the Z38. They transfer him to a secondary or tertiary hospital with higher level of care for maybe some baby with this condition. So then that second hospital then is coding just the diagnosis that the baby is coming forth. They were born there, so you cannot give them that code. These codes can be used throughout the entire life of the patient as long as the congenital condition is still present. So think about that. I think of people that doctor hop and go back and forth, back and forth. You lose a lot of continuity of care when you do that. But with the electronic record, if your hospital or clinic is in the same system, they can share that record. Okay, they'll share that information electronically, through the facility then. The sad thing about that, and I got to put a little plug in that, is if you switch insurances, sometimes our insurance companies do not allow us to go to our hospital. I take that back. I'll rephrase that. You are allowed to go to that hospital, but you're going to pay out of network if you aren't in the network of your insurance company. So I see kind of there's a glitch in the system. So I wish that our government or a state or someone would set up a record, that a database that we could just enter everything, and when I go see a different doctor specialist, they could grab my information from there. So I think that's coming. So if a condition is corrected, there is a code for personal history of congenital malformations. So think about that. Use additional code notes are present in the chapter like they are in all chapters. So for example, to give spina bifida, use an additional code for associated paraplegia if they have that. Cleft lip and cleft palate, use additional code to identify any associated malformation of the nose then. And then as you move through these PowerPoints, and I'm not going to hit each and every one of those, I may just hit the title here, but be familiar with what are the codes and diagnoses that are in Chapter 17. So they're saying under 290 to 99, chromosomal abnormalities, a note appears to remind a coder to use additional codes to identify any associated physical condition or the degree of intellectual disabilities that are present with the chromosomal abnormality then. So to review, Chapter 17 codes are assigned when a malformation, deformation, or chromosomal abnormality is documented. The code may be the principal or the first listed diagnosis, or it can be a secondary diagnosis on that code. So as you get into the chapter specific guidelines, and again, let's back up to Chapter 17 and go to the very front of your coding manual, you will see that they do kind of a review here. So as you read through that in the first few paragraphs, chapter specific guidelines, the coding examples, the malformation, deformation, and chromosomal abnormalities, again, may be the first, your principal or first listed diagnosis, or can be secondary. When these malformations or deformities, chromosomal abnormalities, do not have a unique code, assign additional code for any manifestations that may be present, and we've talked about that in the past. When you have a diagnosis, try to code out fully. You should be able to look just at the codes without any specificity in your tabular and be able to read exactly what that patient's diagnosis are. Okay. So if you've missed something, you have identified a manifestation that doesn't totally give a description of that patient's say, go back to your index, read through your notes, and try to pick up as much clarifying information as you can. Manifestations that are inherent component of the anomaly should not be coded separately. So again, anything that's an integral part of the disease, you do not code out separately. Additional codes should be assigned for manifestations that are not an inherent component of that diagnosis. So you may have to do a little research with the diagnosis that you see if you're not very familiar. So Chapter 17 can be used for the life of the patient. If a congenital malformation or deformity has been corrected, then there is a personal history code. You'd go to history in your index and then look through those to identify the history of that malformation or deformity. Although present malformation, deformity, or chromosomal abnormality may not be identified until later in life. So again, you would be able to pick up that condition. When the condition is diagnosed by the physician, it's appropriate to use those codes from Q00 to Q99 during that patient's life. So at the time of birth, a Z38 category code is principal, followed by any congenital abnormalities then. You will notice that Chapter 17 is organized by the body system, so it includes your limbs, laterality, specific forms of congenital conditions. There are eponyms. Congenital abnormalities are classified in 9 categories to distinguish the, and if I can pronounce these correctly, non-mosaicism, and translocation types of abnormalities. 3 categories of known causes of congenital abnormalities, and again, you may end up doing a little research on this before you start to code these out. Your chromosomal disorders are either hereditary or arising from conception. Maybe their exposure to environmental chemical, for example, medications, alcohol, cigarettes, solvents, or mother's illness during pregnancy, exposing the infant to a bacterial infection then. So stage of fetal development at the time of exposure to one or the 2 lateral causes is critical. The fetus is most vulnerable in that first trimester, as we all know. So we get into a few more of our categories, and they're talking about defects of the nervous system then, the brain, spinal cord, associated tissue. So you have neural tube defects, spina bifida, and congenital defects of the cardiovascular system, again, heart, circulatory systems, the most common groups of birth defects. Surgical procedures, and then, of course, some of the most common defects are patent ductus, arteriosus, arterioseptal defect, ventricular septal defect, and pulmonary artery abnormalities. And we see a lot of those. I work for a very large facility, and we are the main hub for people to come in and bring these abnormalities. Our respiratory system defects will fall underneath these too, so that involves your lung and trachea. Again, other defects may be underdevelopment or lack of development of a respiratory system, may be born early. Other respiratory abnormalities require immediate medical and surgical care to allow the infant to gain adequate respiratory function. Okay, we're almost through this. I'm just going to keep going a little bit here. But again, if you have time, you need to really go back and review the PowerPoints on your own. So it's kind of just a recap and overview. Again, your digestive system and oral facial defects are underneath that. The cleft palate is a split in the roof of the mouth, and you may code out several of those. We don't see as much of those as we used to. Okay, so then we have pyloric stenosis. It's an obstruction of the pyloric opening in the stomach, which need to be repaired. Results from excuse me, I'm catching my throat. Hypertrophy of the circulatory and longitudinal muscularis of the pylorus and dorsal antrum of the stomach then. Usually infant eats well from birth until 2 to 3 weeks, but then has vomited that may lead to dehydration and diagnosed as pyloric stenosis then. Genital urinary tract defects again, defects in the reproductive organs, bladder issues, epistatus, hypospadiasis also then. Obstruction of the genital urinary defect, we have renal issues also of the kidneys, cystic or polycystic disease, also multiple bilateral grape-like clusters of fluid-filled cysts also will affect the kidney function. The next category we're looking at is the musculoskeletal defects, Q65 to Q79. Relatively common disorders and range from more serious again. Then we get into club foot, also, or deformities of the foot also will fall underneath that. So the last, your Q90 to Q99 are chromosomal defects. Again, defects arise from an abnormal number of chromosomes or from defects in specific fragments of the chromosomes then. So we'll give you the list of the more common chromosomal conditions are the Down syndrome, Edwards syndrome, Peto's syndrome, or trisomy 13 comes from the presence of, obviously, number 13 chromosome. Specific groups of procedure codes, as we get into procedures for malformation correction, do not exist. So again, you may have a few of these procedures to code out in your classes. Corrective procedures may be performed in cardiovascular, respiratory, digestive, other body systems to correct the malformations and those deformations. So that was a just nice, quick little overview of excuse me, of the chapter 17 for those congenital malformations, deformations, and chromosomal abnormalities. Now, before I move into my next category or next chapter in our coding manual, I just want you to take a look at chapter 17 in your coding manual. Again, I cannot emphasize enough to take the big picture of working within your coding manual before you start into a chapter. So again, you'll see chapter 17, it gives our chapter-specific guidelines. It also gives you exactly a quick overview of what the PowerPoints were giving us, okay? So they're telling you an 8-day-old infant with tetralogy of blood and pulmonary stenosis, this is how you would code that. For the 7-month syndrome effect, then goes to chapter 17. It tells you right there. You can highlight that. Throughout the life of your patient, the codes may be used. So they give you 3 examples in regards to how to code those out. So take a moment through that chapter, just look at what you will be coding from chapter 17. Okay. We're going to move into our next chapter, actually. It's interesting and can be used quite frequently, I'm going to say, in the the hospital setting, but is not used as frequently in hospital setting as it is in our clinic setting. And I'll tell you why. A little bit here. So chapter 18 in your coding manual is symptoms, signs, and abnormal clinical and laboratory findings. So I just want to give a little bit of an overview of this. This chapter is rarely used in a hospital setting. Why? Pretty much because when you come to the hospital, and if you're going through the ER, they're going to do a battery of tests on you, and they will determine the diagnosis for you. If they can't, and you come in through the ER, if they determine your diagnosis, they will and to the hospital and treat that condition, or maybe they don't know exactly what's going on. So they're going to admit you and do a battery of tests. If, though, you come in for a sign, symptoms, or an abnormal clinical that doesn't require hospitalization, you will be discharged from that ER and told and referred to go to your clinic or acute care ambulatory care center for further treatment. So we're very, very, very careful about that today in our setting because hospital care is so expensive. So we want to make sure that it's medically necessary, and that's part of my job, what I'm doing today, and currently in my field is to review the information, make sure it's medically necessary for you to be admitted to the hospital. So we work closely with our physicians and discuss that. We have criteria that they must meet. If they don't meet that criteria, you can still be admitted to our facility, but your level of care could be observation, or maybe you come in and have an outpatient type procedure done. So we would determine your level of care in terms of if you should be admitted to the facility, and then the different types of level of care. And as I said, we have outpatient in a bed, we have observation level of care, and then we have inpatient level of care. And of course, then most of you understand the different floors or different levels. You can be in ICU, you could be in acute care bed, a respiratory floor, surgical floor, renal floor, pulmonary, depending on your diagnosis. So we do have floors kind of separate our patients by their diagnosis and their care. Okay, so let's take a look at chapter 18. And that, again, is symptoms, signs, and abnormal clinical and laboratory findings not elsewhere classified. The codes are going to be R00 to R99. So if you're in your coding manual, just open that up and just take a look at what you're going to be reviewing through the PowerPoints. Chapter-specific guidelines, coding examples then. It gives you an idea that chapter 18 includes symptoms, signs, abnormal results of clinical or other investigative procedures, and ill-defined conditions regarding which no diagnosis classifiable elsewhere is recorded. So signs and symptoms that point to a specific diagnosis have been assigned to a category in other chapters of the classification. So again, think about what you're coding in this chapter. Symptoms, signs, and abnormal clinical laboratory. Our first one is used heavily. We have a huge cardiovascular in our hospital, and so what we see is patient coming for chest pain. They'll come in through the ER, and they can't determine the cause of the chest pain. Are they having a non-STEMI, a STEMI, a full-blown myocardial infarction, et cetera, et cetera. So they will treat you in the ER maybe for 3 or 4 hours and then determine if you need to be admitted. If your troponin levels are high, your EKG, all of that leads to an issue with the heart, then you can be admitted to the hospital. So we look at B, use the symptom code, the definitive diagnosis code. So again, they will talk a little bit about that. And the first one is pneumonia with hemoptysis then. So they're telling you that codes for signs and symptoms may be reported in addition to a related definitive diagnosis when a sign or symptom is not routinely associated with that diagnosis. So in this case, they're talking about pneumonia. So maybe you don't have hemoptysis when you have pneumonia. Some people do, some people don't. A second example of that is abdominal pain due to acute appendicitis. I come into the ER with abdominal pain, but after further review, they determine I have acute appendicitis. So you would not code that abdominal pain in that case. Let's take a quick review of some of these on PowerPoint, and then we'll move back to some of these examples again of the signs and symptoms. Codes that describe a patient's symptoms and signs range from R0 to R69. So take a look at what the categories we're going to be looking at: circulatory and respiratory, digestive, skin, sub-Q tissue, nervous, musculoskeletal, genital urinary system, cognitive, perception, emotional state and behavior, speech, voice, and general symptoms and signs then. The codes that describe a patient's abnormal findings range from R70 to R97. So for examination of blood, urine, body fluids, they may do diagnostic imaging, function studies, and tumor markers then. One category of codes, R99, identify conditions that are just not classifiable as symptoms, signs, or abnormal clinical and laboratory findings. So take a quick look at that code if you have your recording manual open. Title is ill-defined and unknown cause of mortality then. So let's just talk a little bit about these symptoms. So a symptom is any subjective evidence of a disease reported by the patient to the physician, so such as shortness of breath, chest pain, abnormal pain, and objective evidence of disease observed by the physician as a result of physical examination or test results, such as abnormal result of a laboratory test or imaging study. So some symptoms, such as hives, urticaria, or gastrointestinal hemorrhage, have been classified to specific organ systems in the coding manual. So you would go back to that. What is classifiable to 18 are symptoms, signs that are associated with different body parts or are of an unknown cause. So really, we are looking at an unknown cause. The objective signs are a measurement of or observation confirmed by diagnostic testing. Now, so I come in, I have burning upon urination, I do not feel well, abdominal pain, etc. After doing a urine test, they determine that I have full-blown urinary tract infection with an E. coli. So abnormal findings include objective measurements, as I stated, your lab reports, your function studies, cardiac exam. Abnormal tumor markings are also an objective measurement of biochemical substances that are indicative of the presence of a tumor then. So Chapter 18 includes all of that: symptoms, signs, abnormal results or of clinical or other investigative procedures, and ill-defined conditions regarding which no diagnosis classifiable elsewhere is recorded. You have depleted your entire resources. The physician has found nothing. You're going to go back to find your symptoms. So if I come in with chest pain, they find nothing, everything is totally normal, I'm going to code it out as chest pain then. So sub notes under the guidelines: signs and symptoms that point definitively to a given diagnosis have been assigned to a category, obviously in an other body system of the coding manual then. Categories in the chapter include the less well-defined conditions and symptoms without the necessary study of the case to establish a final diagnosis, and they point equally to 2 or more diagnoses or 2 or more systems in the body. So again, excuse me. And that's, if you have your coding manual open, you can follow along with some of the exercises that are an example within that section. All categories should be designated not otherwise specified, unknown etiology, or transient then. So cases for which no more specific diagnosis can be made, even after all the facts bearing on the case have been investigated. Signs and symptoms existing at the time of the initial encounter that proved to be transient and whose cases could be not determined. So provisional diagnosis in a patient who failed to return for further investigation. Some of the other notes in the chapter are cases referred elsewhere for investigative or treatment before diagnosis was made, cases in more diagnosis was not available for any reason then, and then supplemental information that is provided that represent important problems in medical care in their own right then. So many of the blocks and categories within this chapter have excludes ones, and you know what excludes ones in. If you don't, remember to go back to the beginning of your coding manual and go through the conventions and the format of the book. So those coding one notes that will direct that coder to locate a diagnosis code that appears in other chapters. So it's making you take a second look. You know, as you look at those exclude notes, is it included? If it's mentioned in that diagnostic statement, then you may want to look at that excludes note. Guidelines that clarify code usage are also found under those specific codes. So again, reading your notes is very important. We have Chapter 18 guidelines will address the symptom code, a symptom code with a definitive diagnosis, and you can follow along with me here. Excuse me. Combination codes include symptoms, repeated faults, that is D in your coding manual, that is R29.6, and it gives you a little bit more of an overview. Look at the coma scale under E in your coding manual. It tells you the glaucoma, or excuse me, the Glasgow coma scale, if someone comes into that, the Glasgow coma scale again, and they have a great example. So 23-year-old man found down. So review through that, work your way through that, look up the codes, work through the index, see how they found those and how they arrived at all those codes for that patient there. SIRS due to non-infectious process, again, death not otherwise specified, and then the MIHSS stroke scale also, and that is very interesting, and you should do a little bit more information on that if you are not familiar with the stroke scale too. So and the other thing about both of those, or the stroke scale for sure and the Glasgow, your physician has to document that. It has to be listed in your documentation in order for you to code that out. You can't just guess on those and say, well, I think it's this. Your physician needs to definitely tell us that is the scale and the number that that patient is at. So R00 to R60, symptoms and signs by body system, conditions that are routinely associated with a disease process. Again, they're saying symptoms and signs that are routinely associated with the disease process should not be assigned as additional codes unless otherwise instructed by the classification. If your coding manual is taking all the work out of that, as we talked about appendicitis with abdominal pain, you would obviously have abdominal pain with appendicitis. The hemoptysis with a pneumonia, you may not have that symptom. So it's an additional code that can be added. So follow your notes within your guidelines there. So for example, nausea and vomiting with gastroenteritis, you'd only code the gastroenteritis. So again, you're learning a little bit about the disease process or signs and symptoms. Then conditions that are not routinely associated with that disease process, as I just stated, should be coded when present. For example, they state a patient with metastasis to the brain and in a comatose state, the code for coma should be assigned, and it is not routinely associated with metastasis then. So in that case, here's our coma scale, the Glasgow coma scale. The GCS is a method to describe the level of consciousness of patients with acute brain injury that could be a result of trauma, neurological disease, or other etiology. And I use this frequently, especially at the time of year we have a lot of accidents, a lot of 80-mile-an-hour accidents hitting black ice and flipping the car. So we see a lot of these, and our physicians are very good to describe this. And this is the criteria that they would use. I won't read through that, but your coma scale then will tell the exact what they're looking at for that. So also your R4.2 coma incorporates the Glasgow scale. These codes are used in conjunction with the traumatic brain injury. Again, someone maybe that had a severe accident, something happened, or sequela of cerebrovascular disease. These codes are sequenced after your diagnosis then. They talk about the 7-character extension indicates when the scale was recorded, it should match all 3 codes. Okay, so keep that in mind. A little more about the coma scale again, so you know that is there for you. Your altered mental status, etiologies, workup, etc. So the general symptoms and signs, there is a block of general symptoms that are not related to one specific body system. And so examples of those symptoms include your fever, headache, malaise, fatigue, syncope and collapse, convulsions, SIRS, and sepsis then. You can also code out abnormal findings from the laboratory if they think they're pertinent then. So main terms in your alphabetical index are abnormal, abnormality, findings, abnormal, decreased, elevated, high, low, or positive. So a lot of times patients will come in with an elevated blood pressure with not anything else documented. So you can pick that code up also. It just tells a better story about why the patient is there. The rest of the PowerPoint slides will also talk about abnormal findings from lab and x-ray. Those are not coded unless the physician indicates their clinical significance. So you cannot just be picking things up off of another report unless your facility has said it's pertinent, and they'll have guidelines in regards to that too. But you must really query your physician, and if you think he's missing something, that is pretty rare. Abnormal findings of one test may be the reason for of the conditioning. Excuse me. Coders are allowed to use the radiology's finding to add specificity to the diagnosis. So again, you may have a certain type of pneumonia, right left lobe, etc. Then you'll be able to pick those. You go to your chest X-ray lab and be more specific with that code then. The title of R92, abnormal and inconclusive findings on diagnostic imaging of breast, means an inconclusive finding was made, but is not necessarily abnormal. Again, someone may find something on a mammogram. Is it just a calcification? Does it require more testing, etc. then? So they talk about the pap smear. Test results are often abnormal findings. So again, this is a huge, the psychology part of it has a big piece of it then too. So you are depending on your physician to give you that documentation then. Abnormal tumor markers also will want to be noted if they are something caught in a hospital stay. Maybe somebody comes in for an accident, they do all these scans, MRIs, and they find something that's elevated or doesn't look right. So that's something that the tests are done for diagnosis of, and the follow-up care for malignancies also. Last but not least, we have ill-defined and unknown causes of mortality is R99. So that includes death, unexplained death, or other conditions that are specified causes of mortality. The code may be used for a patient who is brought to the hospital ER but has died prior to arrival, and the diagnosis written is dead on arrival then. There may or may not be resuscitation depending on the circumstances, and the reason for death is unknown. Now we get into a little bit of the diagnostic ICD-10 PCS procedure coding to investigate symptoms, signs, abnormal clinical and laboratory findings. So again, it may do some diagnostic procedures to investigate the abnormal findings. Medical and surgical section codes may be used to perform biopsies. Inspection procedures are bronch, cysto, colonoscopy. So any of those diagnostic measures are something that you're going to pull from the procedure section. Administrative codes identify procedure for putting in or on, and you've learned that in a separate class totally from our diagnosis class. And again, the 7 characters used to code administrative procedures to be used. So main terms used to find the PCS codes are transfusion, introduction of substance in or on again. Measurement, monitoring, etc. Those are some that you will maybe picking up. A lot of codes are very definitive codes in a hospital type setting. So codes in the imaging section, your CT, MRI, ultrasound, again, those are main. You go to your main terms to locate those procedure codes. And again, in a hospital inpatient setting, those are captured by a charge master and already pulled through. If you're coding for ambulatory or outpatient or physician coding, then you may be the one assigning those imaging section codes. All right, we are moving along. Take down this one, bring another one up. And I'm going to get into our chapter 19, and you'll see from here, injury, poisoning, certain other consequences of external causes. So we'll do a little bit more of a review. There are 46 PowerPoints on this, and I apologize if you think I'm speeding through it, but it's something that you can pretty easily review yourself. So let's get the gist of the chapter. So chapter 19, let's take a look at that. And I want you to notice something. Look how big this chapter is. Okay, just take a look. I am in a professional edition and I have an expert edition, but that is a lot. That is one of our biggest chapters. So just take a moment. I want you to look at chapter 19, injury, poisoning, certain other consequences of external causes. The codes are S00 to T88 then. Oh, and it looks like this PowerPoint, I apologize, has broken down. I have two PowerPoints for this, so that will hit this. So what I would like for you to do is just open up your coding manual. Let's just take a quick look at what we are going to be reviewing here. Your chapter-specific guidelines with coding examples is an excellent way to start. You know, the guidelines are coding in the, along with the guidelines are coded examples in those shaded boxes. And so they really do help us with coding and sequencing guidance to help follow those guidelines. Remember the application of the 7 characters in chapter 19, so you will be utilizing that where it is indicated. And mainly, a lot of that 7 character could be for initial encounter where the patient is receiving active care, etc. So they give some very good examples of this. So it would behoove you to work through the shaded boxes in lavender and do some of those exercises just to get an idea. And for me, as a beginning coder or even an old coder, if I can take a glance at what my exercises are and examples in the coding manual, it's going to be a lot more effective than reading through PowerPoint. So I'm kind of mandated to read through these official coding guideline PowerPoints to you, but in my opinion, it would be time well spent to work through some of these exercises. Just read the question that they're talking about and then cover up the answer. Take an index card, cover up the answer, and see if you can't figure out what the correct answer is to that. So let's talk briefly about chapter 19 focuses on traumatic injuries. If you take a look at your coding guidelines and then just go right into the chapter, what you'll notice, excuse me, you have a muscle and tendon table before you get right to those coding guidelines. But look at the different injuries. You have injuries to the head, injuries, intracranial injuries, nerves, spinal cord, open wounds, superficial injuries to the arteries, a foreign body, traumatic rupture of wrist, ligament of the wrist, etc. So again, these are some of the your injury, poisoning, other consequences of external injuries, external causes of injury to the person. So once you code from your main category and get all your diagnosis down, then you're going to want to tell them what happened, where the exact injury was, traumatic amputation of a finger, etc. So you have a situation where a patient comes in, maybe they've had a car accident, and you can code. There's a T code for those, an overall injury code, but so, and again, throughout these diagnoses, you have the poisoning code. So someone has come in, maybe they've been poisoned. You have to remember to use your A for initial encounter, D for subsequent encounter, or S for sequela. Okay, so I'm going to just hit a few of these as we are kind of hitting an hour time limit here. So chapter 19 is traumatic injuries. So they are arranged by body region, beginning with the head and concluding with the ankle and the foot. Grouping of the injuries types together under anatomical site where it occurred. Other conditions include burns and frostbite. And again, as I kind of mentioned, a few of those, listing of the conditions that follow that anatomical site. So superficial injury suggests as an open wound or fracture, dislocation and spraying, injury of blood vessels, crushing injury, traumatic amputation, other unspecified. Then we move into burns, and we've already talked a little bit about burns in a previous chapter, but T20 to T22 are classification of burns and corrosion. Again, identify thermal burns, except sunburns that come from heat source, but from electricity and radiation. Corrosion are burns due to chemical events. And again, at the beginning of chapter 19, there's a note to use secondary codes from chapter 20, which are external causes of morbidity, and that's our last chapter that I'll hit a little bit on too. So codes from the T section, as I talked, about Chapter 19 do not require external cause code, as external cause is included in that code title. So that would maybe your only code you will use. Insurance companies don't necessarily like those codes, but ICD-10 contains a note under the different categories to open wounds to direct the code or decoding associated wound infection. And here we talk about your seventh character. So A, initial encounter, D, subsequent encounter, or sequela to the event. Then, fracture extensions are unique to the type of bone. Their codes are open as well as episode of care. Is it their initial encounter? Are they coming back to have the cast removed? Are they having issues? Or sequela? Is there a residual or maybe a malunion of a fracture that didn't heal right? So again, these chapters guidelines, application of 7 characters, coding of injuries, coding of traumatic fractures, coding of burns and corrosions, and they use 2 alphabetical letters as the first character of S and T. So S provides codes for various types of injuries related to a single body, and T section covers injuries to unspecified body regions as well as poisonings and certain other consequences of external causes then. Okay, so then they get into the placeholder character X. So remember, you'll be utilizing that to arrive at your 7 digits. Character 6 is used to fill a position to allow the addition of the 7 character to complete the code. Okay, so for example, we have initial encounter for laceration of foreign body of scalp, and the X is your placeholder then. Here's an in-depth listing of the 7 character. A for initial encounter, D for subsequent. They tell you exactly is used for encounters after the patient has received active treatment of the injury and is receiving routine care for the injury during healing or recovery phase. Your 7th character, the S for sequela, is used for complications or conditions that arise as a direct result of an injury. S is added to the injury code, not the sequela or current condition then. All right, so throughout the rest of this long PowerPoint, I think there are 50 PowerPoints, you will find that they'll talk about the types of codes, your fracture codes, all the way through this. So I'm not going to go through this. This is something you should have learned in previous anatomy and physiology classes also. But don't sell yourself short. Make sure that you review the PowerPoints because they talk about the 7 characters and how they can be used in a little bit more definition, which is also in your coding manual. Okay? All right. Multiple fractures. Lots of great information. So when you hit these codes or this chapter, make sure that you pull up the PowerPoints, do a quick review. They talk about the burns, what constitutes 1st degree, 2nd degree, or 3rd degree burns. Again, multiple injuries, etc. And I'm just going to breeze through a few of these. Injury to blood vessels, the nerves, and spinal cord. Again, you'll have a 7 character for all of these that we are discussing. Traumatic amputation, effects of the foreign body entering through a natural orifice. Again, so make sure that you are familiar with that. You're still using those initial characters and that 7th character. They talk a lot about the coding of, procedure coding related to the treatment or injuries. Obviously, a coding fracture treatment, repositioning. Objective, physician may use reduction. I'm going to back up on that one. Instead of repositioning, and that's your term in your index to find that procedure code. Coding fracture treatment, and your root operation is insertion, immobilization, etc. So this is something that you've had in a previous class and should be familiar with, but maybe you need a little bit of a refresher. So the PowerPoint does a great job of that. All right. And I believe I'm going to just kind of breeze through our poisoning because we still have, and that's still in Chapter 19. Okay, so we're still working in Chapter 19. We have one more chapter to go to review, and that is your external causes of morbidity, and I think that will be fairly easy for us to review also today. I'm going to close this one down. Takes a moment here. Okay. So again, this PowerPoint and the second part of your chapter focuses basically on poisoning and certain other consequences of external injury. So you can actually start T36 code, where I just happened to pop into here. And this is a little bit different than your first injury code. So you have injury, your first section of Chapter 19, and then we have poisoning. So, so we have S00 to T88 are the codes, and they talk a little bit about the combination codes, identify whether the condition was poisoning, adverse effect, underdosing, or of a drug or biological substance. These codes include external cause such as accidental intent, intentional self-harm, assault, or to be determined. So again, that's something that you're going to need to know from the chart. Was it an attempted suicide, just the overdoses of maybe a child got into something, etc. How were they poisoned by that? Or maybe they took a drug correctly and they did a poisoning. So there are some definitions to underdosing again, and this is what they talk about, defined as taking less of a medication than is prescribed by the manufacturers with resulting negative health consequences. So they do the underdosing. If you have not heard of that, as a consequence, the patient may suffer a worsening of the condition intended to be treated by that medication. So be sure to read all of your notes. Instructional notes appear under the subheading for T36 to T50. They're telling you code first, adverse effects, the nature of the adverse effects, such as aspirin gastroenteritis, blood disorder, contact dermatitis, they have a rash, and then you're going to be coding from your T36 to T5 then. Instructional notes appear under the section heading for these. Note the drug given rise to adverse effects should be identified by the use of categories with 5th and 6th character 5. More instructional notes for manifestation of poisoning or underdosing then. And then Chapter 10, chapter-specific guidelines still apply to that, okay? Do not code directly from the table of drugs. That is forbidden. You must always go back into your tabular and determine that. And one second here, I'm looking at something for you. So as we talked about earlier, right behind the neoplasm table, or the ends in your index, and I apologize, I should start there as I reviewed this, but go to your table of drugs. And this is where you will start in your index. You'll find your drug, and then you will determine by the category if it is poisoning, accidental, intentional assault, undetermined, adverse effect, underdosing. Okay, so that is where you will start in the index. So in your index, right after the neoplasm table, you'll see table of drugs and chemicals. Fairly easy to use, okay? And then once you find your code, then you pop into your index where we were of the poisonings, injuries and poisonings, and you work your way through those and read through the guidelines and the notes. Okay. All right. So again, this is a fairly lengthy PowerPoint that you should review through. There's 45 slides on this too, and they do discuss in depth the coding nodes of the poisoning. And the one thing that I want to bring up about this is that if you should be very good at this by now. You should be reviewing the adverse effects. For instance, the PowerPoint that is up, it tells you to locate the drug in your index, assign your 7th character, etc., and then keep moving forward. If the same drug produces more than one manifestation, the coder should assign the drug code only once. If 2 drugs are involved, do the combination code, etc. So again, PowerPoints are great to review, but your definitions and notes within the tabular are what you need to follow verbatim so that you arrive at the correct code. So a quick overview of the poisoning chapter. We'll get huge into depth into the poisoning section. A poisoning can occur with prescription drugs, over-the-counter drugs, illegal drugs taken with alcohol, beverages, etc. Very intense. So if you're working at a facility maybe that you see a lot of this is going to be your forte. You will know these guidelines like the back of your hand. So I'm starting here with the PowerPoint on 26, but instructions for coding poisoning. So there are multiple steps for that also, but use your table of drugs, which I just had shown you. Go to the poison column, next code out all specified manifestations or the effect of poisoning. Okay, and just make your way all the way down through that. So they talk about underdosing, toxic effects, injuries, Complications of surgical care falls underneath this also. T80 to 88. I use a lot of these codes. And again, codes for complications must be based on provider's documentation that makes a connection between the condition and the medical care that apparently caused it. Okay. Some of the complications in this chapter have the external causes as well as the condition included in the code. So again, think about that. So a patient had a central lung infection due to the presence of that central venous cath. So again, you will have a seventh character indicates if the condition is treated in the initial setting, subsequent, or is it a sequela of that? Codes with the category include post-procedural shock, disruption of operative or surgical wound, infection following procedures, complications of foreign body, acute reaction to a foreign substance accidentally left. So again, excellent PowerPoints in review of that, but you've got to read your notes. And if there's something you don't understand, pop back into a PowerPoint and make sure that you go back to the beginning of your chapter and review through the guidelines. So the last few PowerPoints will relate to surgical procedures performed to treat those complications again. So they just give you a few tips on how to find those also. All right. Large chapter, but very straightforward notes of how to code out the poisonings, injuries, etc. Okay, I'm going to save that one. And now, our last but not least on this section is external causes of morbidity. So not as many PowerPoints in relation to this, the T codes. So let's open up your coding manual and let's just take a look at what are we going to be looking at when we talk about external causes of morbidity, which is V00 to Y99. So as you read through that, the external causes of morbidity code should never be sequenced as the first listed or secondary. Right there is a huge tip in regards to this diagnosis section. So external causes are intended to provide data for injury research, evaluation of injury prevention strategies. These codes capture how the injury or the health condition happened or caused the intent. Was it unintentional or accidental? Or intentional, such as suicide or assault, the place where the event occurred, the activity of the patient at the time of the event, and the person's status. That is, are they civilian? Are they military? So again, very, very specific codes to help identify what has happened to that patient then. There is no national requirement for mandatory ICD-10 external cause coding. Unless a provider is subject to a state-based external cause code reporting mandate, or these codes are required by a particular payer, reporting of the ICD-10 codes in Chapter 20, external cause of morbidity is not required. In the absence of mandatory reporting requirement, providers are encouraged, though, to voluntarily report external cause codes as they provide valuable data for injury research and evaluation of injury preventive strategies. So again, take a look at your guidelines before Chapter 20 and just look at the diagnosis or the situations that they are coding out. Actinic reticular due to tanning bed use. So again, how important do you think that would be? And where are people getting those statistics for the advertising? This is where they're picking this up. Maybe someone has this disorder due to exposure to tanning bed. External cause code used for a length of treatment. That could be of value also. And again, remember, these external causes should never be, the VWY code should never be used as a principal diagnosis. So as you look through these, you'll see place of occurrence, a barn as place of occurrence of external causes. Someone had a contusion to their foot, other contact with horse, activity, grooming, and shearing of an animal. So it's kind of interesting. I kind of enjoyed the chapter and just to look through it. Multiple external causes of injury, again, accidental discharge of a hunting rifle, which caused a comminuted fracture of the shaft on steps, etc. Child and adult abuse guideline, again, that is something that is mandatory to be reported to the state, so you may want to follow those guidelines also. Terrorist guidelines, cause of injury identified by the FBI as terrorism, cause of injury suspected to be a result of terrorism, etc. So how many, maybe a hospital wants to know how many patients they saw, due to a crisis situation, a terrorist act. Do they need to be more prepared for that? What can they do to triage and maybe do better in getting these patients through it? So external cause status again is just indicates whether the event occurred during a military activity, whether it was a non-military, etc. So again, review through those, and then the next suggestion I would have is just to take your finger and go through chapter 20, external causes of morbidity, and just see. You'll see accidents. We have transport accidents, and then they go into specific from A through, I think we go through Z, and that is telling you how it has happened. Were they a motorcycle rider? Were they the driver? Were they passenger, etc. So you can be very, very specific. Pedestrian injured by train, motorcycle rider injured in transport accidents. You can see these are the external causes of morbidity, and we do use those. We really do. I work in a rural setting, and they're very good for being active in terms of keeping your community safe. When I worked in a 40-bed hospital, we didn't have all of these codes. We had a few, but they wanted to know. I remember, shows I'm a farm girl, but when the big round balers came out, and they were having so many accidents of people, they would get balled up in there, and so the farmer would reach in, and it would just it would kill them. I mean, they'd get their arm caught, and then they would be wrapped up in there, and it was horrible. So that was one thing that by into 6 months or whatever, we had collected the data on that, and then we'd send it to our state or send it to our, at that time, it would be our, lack of a better word, not 4-H, but the government entity that looked over our rural health, and sent it to them and said, hey, we've had, 8 accidents, 2 fatalities from a big round baler, and it was just from a research. No names were attached. It was just the data, the percentage of what our accidents are happening to. The other way we used this type of data was of our physical therapy would use the last 2 chapters that we just talked about, the injuries and the poisoning and that. We ended up developing a statistical sheet for our board to say that we really thought we could benefit from having our own physical therapy or PT department attached to the hospital instead of at the clinic, but we could do rehab, we could do physical, speech, occupational therapy, and so we ran some numbers for the past 4 or 5 years and added a room, and in the end, after a year, we figured we could pay for an actual adding on to the building and the equipment, a full-time physical therapist with a part-time assistant, and that's how we determined that was just by the codes and the statistical data gathered from our ICD-10, at that time, ICD-9 code. So very interesting. Okay, so just our last little bump here on the external causes of morbidity. I just really think it'd be best if I don't need to brush through how many got 34 slides here, but just take a look at chapter 20 and the blocks or the categories that you'll be hitting. It kind of should stick in your mind, hey, somebody had an accident. Can I fully explain what happened to them? The insurance companies want to know because all these codes are going into an insurance company, and they're looking at them to see what happened to the patient and what they need to do next. Then does your insurance cover this, etc. So again, take a moment and just peruse through chapter 20. Very interesting, very detailed information, but it does definitely, I think, will stick in your mind a little bit better if you take that moment to review the codes and what is actually there. Here's the military operations, operations of war, military operations, terrorism. Again, those are some of our codes for that too. And that is it. So thank you for joining me today, and you can stop and start this little PowerPoint presentation over these chapters that we completed today. And I thank you for joining me. Again, this is your coding manual, so if you're using any kind of a textbook that goes along with this, just open that up and you'll see we did Chapter 17, Congenital Malformations, Deformations, Chromosomal Abnormalities. Chapter 18 was Symptom Signs, Abnormal Clinical and Laboratory Findings. Chapter 19 was Injury, Poisoning, Certain Other Consequences of those external causes. And then we briefly discussed Chapter 20, the External Causes of Morbidity. So thank you for joining me today. I look forward to visiting with you again. Thank you.